Welcome back to Health Law Pulse. I'm your host, John Rhodes, healthcare attorney and founder of Health Law Counsel LLC. I have to first apologize for my voice. I'm recording this introduction and outro on Thursday, May 14th. I'm getting over some slight chest congestion, but I was also at Game 5 of the Colorado Avalanche Minnesota Wild NHL playoff game. The good news is that the good guys won, the Colorado Avalanche, of course, an exciting overtime game, and they are on their way to the Western Conference Finals. The bad news is that the environment was a bit raucous, and it did no favors for the quality of my voice. Fortunately, my interview with our guest today was recorded last week. I'm very excited about this episode and our guest today. This episode takes us inside one of the most complex environments in healthcare, the hospital. Hospitals are systems built around constant decision-making, coordination, communication, and time pressure. And while a lot of attention is given to policies, regulations, and technology, and rightfully so, the reality is that patient outcomes are often shaped by how well teams operate in real time. My guest today is Dr. David Jackson, a hospitalist here in Denver, Colorado. In this conversation, we talk about what hospitalists actually do behind the scenes, where communication and coordination most often break down, and how operational challenges inside hospitals quietly create risk for both patients and providers. We also discuss transitions of care, leadership in high-pressure environments, and the realities of practicing medicine inside increasingly complex healthcare systems. I think you'll enjoy this episode and find it very insightful. This is Health Law Pulse. Okay, Dr. Jackson, welcome to Health Law Pulse. Thanks for carving out some time and joining us today and giving us some great insight. I'm very much looking forward to this conversation.
Absolutely. Thank you for having me.
So, absolutely, really happy to have you here. Dr. Jackson, I'd love just to start off telling us a little bit about your background, a little bit about yourself, and we'll just dive in from there.
I'm a functional Coloradan, moved here when I was a young child, and then had a few kind of diversions on my way into medical school. So spent some time working in the theater and working as a rafting guide and
Oh,
getting
wow.
some less academic pursuits, and finally found my way into medical school, and then did residency in family medicine and was drawn to some of the kind of primary care, whole person kind of approach to medicine with family medicine, but really enjoyed the acute care and hospital care. And so have worked my whole career thus far as a hospitalist. So all doing inpatient care.
That's fantastic. And no regrets. So you were a rafting guide. You were, you were in theater and you chose medicine. No regrets there.
I mean, obviously, you'd love to be able to have a professional income with a recreation lifestyle, but
Fair, fair.
on balance, no, this has been fantastic.
Excellent, excellent. Well, I'd love to start right there, Dr. Jackson. I started practicing law about 20 years ago, and before that, quite honestly, I didn't know what a hospitalist was, and I didn't know what a hospitalist did. And we represented a fairly large hospital that employed hospitalists, so I had to quickly learn exactly what they did. So, for those outside of healthcare, what does a hospitalist actually do day to day? How would you describe that?
Yeah, well, it's not unusual at the start of your career to not know what a hospitalist was because the term hospitalist only came into existence about 30 years ago. It's been something that's been growing, especially over the last couple of decades, where we kind of stand in for your primary doctor when you're admitted to the hospital, and so. We're doing all of the general care of, in my case, adult internal medicine, but there's also OB hospitalists and pediatric hospitalists for other specialties. But if you need to be admitted to the hospital for some reason outside of, say, an elective surgery where your surgeon is your primary physician during your hospital stay, we're the ones that take on that role. And so if it's a medical problem that's within our scope of care, we'll be able to treat that or direct the treatment of that. If it's something that needs multiple specialties involved, then we'll be consulting the appropriate specialties, coordinating amongst the different opinions of the different physicians on the case and trying to bring it together to the patient and their loved one and support network as far as what we're going to be doing, how we move forward, and getting the entire sort of symphony of team members within the hospital working together to try and keep that person's patient moving forward. It's been interesting, as hospital medicine has gotten more and more acute, people are getting more and more complex medical problems, and the care provided is more and more fast paced. The ability to have a private practice, so make morning rounds and then go to your clinic all day and then come back and check on your patient again in the evening, really doesn't match the just never ending phone calls and communication that we do through the day. So having somebody based in the hospital where that's their whole job ends up being pretty beneficial.
Yeah. That's very interesting. And so it sounds to me like hospitalist, there's a lot of care coordination going on. And in hospital medicine, I think has really become the central part of modern healthcare. And certainly CMS and DH, I mean, they've all recognized this, right? I mean, a lot of the payment incentive models, they revolve around treatment at a hospital. Why do you think hospital medicine has become such a central part or a core part of modern healthcare?
But the hospital care is one of the most expensive parts of healthcare in general. People are often looking from if you're looking at it from a cost containment perspective, you're saying, well, how can we not have those cost outlays for somebody who is hospitalized? And what can we do to make it more efficient? From a care perspective, it's often, well, people have hit a crisis, whatever either the degree of their illness or the inability to get tests performed or get coordination among specialists or whatever it is that they've decompensated to the point to need to be hospitalized to make all of this happen. These are some of our sickest patients. Some of the sickest people in the country are the ones who are in and out of the hospital all the time. And so we end up having a big role to play in the care of some of the people who have a lot of healthcare utilization, a lot of healthcare needs. And we are often kind of shining a light on the lack of care. And that's not to denigrate the people who are trying to provide that care in an outpatient setting, but just the difficulties in getting complex care managed and coordinated when you're having to schedule an appointment and make it to a clinic and then go somewhere else for the follow-up clinic. It's just hard to do all of that, whereas we've got so many resources under one roof.
You went exactly where I was wanting to go because hospital medicine is really interesting to me, but it's not something that I've really addressed or talked about too much on this podcast because it's very complex. In the hospital environment, there's so much complexity. The hospitalist sounds to me like, I mean, you're at the center of it all, where someone comes in with an acute condition, you treat that patient, but that patient already has a PCP. That patient already has, depending on the condition, comorbidities, has a variety potentially of different specialists. What what makes the hospital environment so complex? Is that, and where do the breakdowns? I guess what I'm most interested, where do the breakdowns most commonly occur? Because I can imagine communication is key,
Yeah.
organization is key. I mean, all this with that level of complexity, potentially, I would imagine invites a number of opportunities for breakdowns. So where does that commonly occur?
Records and reading and communicating and
Yeah.
working with incomplete information. So my undergraduate English degree, where it's a lot of the courses were, here, read a novel, have it done in a couple of days and write me a paper about it.
Right.
Well, what am I doing when I'm digging into charts? The electronic medical record, Epic is sort of the big hitter in the EMR space. And the different Epic systems, each hospital group or each healthcare group can purchase their system from Epic. And you work within your own system's EMR, but you can see the other systems. EMRs. So, here in Colorado, UC Health and Intermountain Health and Boulder Community Health, Advent Health, Common Spirit, all utilize Epic. So I can, if someone gets their primary care at UC Health, but they have a Boulder Community Health cardiologist, and then their obstetric care was with Advent Health, you can
Mhm.
look into all of those records, but it's not seamless. So you end up spending a lot of time trying, well, let me review this set of labs, and then let me review this set of notes, and let me try and pull all of this together. And all of it is people who are working in a clunky system. So you're entering in diagnosis codes and just trying to make it through the encounter so you can provide the care that you need to do. But then it ends up just sort of building up in the EMR. So you can
Mhm.
go through and you read, and I'll go in, I'll spend some time reviewing the chart before I meet my patients for the first time and try and get a sense of, well, what meds are you on? What conditions do you have? What other hospitalizations have you had at what other facilities in addition to our own? And then go and try and have some degree of truth checking with the person. I said,
Mhm.
"Oh, I understand you have heart failure, diabetes, whatever it is." And sometimes you get the confirmation. Sometimes you say, "No, I used to, but my doctor took me off of all of those medications and that's just not reflected." Or sometimes there's just a lack of knowledge as Like, people who think, no, I don't have diabetes because it's been treated now because I'm on 5 different meds for it. Well, if you're still on those meds, you still have it. It's not gone now. So you try and kind of synthesize all of that information, and then you know that it's not all going to be there. It's not going to be complete. There's going to be holes, there's going to be gaps, there's going to be nuance. I'm meeting my patients often for the very first time when they're getting admitted to the hospital or when we hand off service and I'm picking up their care in the middle of their hospital stay. Compare that to, say, a primary care doctor who possibly has even a multi-decade relationship with somebody and knows their kind of quirks and foibles over
Right.
the years. And so I'm trying to negotiate, like, okay, so it seems based on what your record says, you have this set of conditions that are a priority. Based on talking to you, you have this set of concerns that are a priority. Based on what I'm seeing with our data and diagnostic testing here, we have another set of concerns. Where do those overlap? What are things that I need to address or that I need to change now? What are things that I can just accept? I don't know all of the details, so I'm going to ask you to go back to your primary doctor because I'm assuming I have gaps in my knowledge as far as, what is your nuance, your history, all those things. So what do I need to do now? What is something that I have a pretty good idea? I have a strong opinion on what you should do, but go talk to your primary doctor because they might actually know more than I do or have a completely different take on this.
Is this something they teach you in medical school? There's a lot
Sort
there's a
of.
lot of coordination going on here.
That idea of to take the history, get the background data, synthesize it, that's all taught. But some of the how do you then apply that to a particular person? It's the practice of medicine. You just keep trying to figure it out as you're working through day by day.
Yeah, yeah, and, interesting on the EMR piece, I think a lot of the larger provider groups I've worked with, the national groups, they either have Epic or they have a pretty sophisticated way to integrate or speak to Epic, but not all PCP groups have that, and so you may have a patient that presents at the hospital, you're treating that patient, they have had a PCP for 30 years that has some antiquated
Mhm.
EMR. How often does that happen, and what sort of challenges or problems does that present?
Frequently, and there's just a lot of unknown.
Yeah.
There's a lot of, we will spend several days caring for someone saying, well, I presume they carry this diagnosis because they've been prescribed this medication, even though they're uncertain and it's not ever stated or confirmed anywhere. And so there's an awful lot of, well, I think it might be the case, but
Mhm.
it's not actually central to what's going on now. We don't
Right.
need to change that medication, stop that medication, do something about it for what it was that brought you into the hospital. And then there's the ones that unknown does seem to be central to what's going on. And even then, you can say, okay, well, I'm going to make the recommendation because based on what I'm seeing, I think it was your blood pressure medication that actually caused your electrolyte disturbance that is what caused you to be confused and land in the ER. Okay,
Mhm.
so here's what I think you should go talk to your doctor about not taking this medication ever again. But I don't know. Maybe they have a wonderful reason for why that's actually the best possible option for this particular person, of which I'm just unaware. And
Right.
so there, you just sort of are left with an awful lot of uncertainty and making a recommendation rather than a strict thou shalt kind of dictate
Mhm.
for what they should do.
So this is why I think what hospitalists do is so interesting because the way you've described it the last 10, 15 minutes we've been talking is you have to make decisions with a lot of incomplete information.
Mhm.
So I suspect that you're constantly balancing this situation of incomplete information and time pressure to act based on, whatever the conditions the patient who's presenting has. And so how do you make that decision? Is it really as urgency based on your professional judgment on how do you make those decisions when you're trying to balance an incomplete record or incomplete information with the time pressure that you have?
And I guess that, it really gets into, well, what's the condition? What is the emergency? And what is the crisis? So if it's something that you need to respond, whether you know the answer or not, clearly you do it. If it's something that you could potentially cause more harm than benefit by responding and jumping into something before you actually have the result of the testing or the specialist consultation, then you wait. There's a lot of data on what are the things that can hurt people quickly. So, sepsis care. If
Right.
somebody is infected and is hospitalized with sepsis and you don't start their care quickly, you can definitely cause them harm, or you can let the harm happen without intervening, I guess, more specifically. So we'll often initiate care while we're working to diagnose, whereas something potentially, sounds serious and catastrophic like a cancer. Well, there's often a degree of slowness to that. If I respond now versus tomorrow, that's probably not going to make a big difference. Now versus 6 months from now clearly would make a difference. But do I need to start you on some, say, a medication or a treatment that could cause you harm today before I actually have the results of the testing back? That 1 day delay is not going to hurt you. And so it's really looking at, well, what are the things where the risk of doing nothing outweighs the risk of doing something? What are the times where the risk of doing something actually outweighs the risk of doing nothing? And you should just stand there. And that can
Right.
be very hard.
Oh, I'm sure. I'm sure. When mistakes do happen, I'm sure they do from time to time. Is it commonly a communication issue, or what role does communication play in avoiding those mistakes?
Yeah, they talk a lot about sort of the Swiss cheese model of
Mhm.
mistakes, and that you often have to have a number of errors line up to actually have a bad outcome occur. And so, as far as what type of mistakes happen, obviously the communication, we're talking about incomplete information, not knowing somebody's whole history, or that their, primary doctor had carefully avoided a certain medication because they had seen problems before. We don't know that. We start them on that medication. They didn't remember that they had had problems before.
Right.
So that lack of knowledge can do it. There can be just errors. The wrong medication gets ordered, the wrong test gets ordered. And often there's people that catch that. So if I order the wrong medication, our pharmacists are checking all of my orders and saying, hey, Dr. Jackson, did you really mean to do this? So that's sort of the first layer of defense. And
Sure.
the nurses are the ones that have to administer it. And so you get another set of eyes, another trained professional saying, wow, this really makes no sense. Why would this person get this medication? And
Sure.
they call and say, hey, before I give this, did you really mean to do this? So you get for that type of error, there's a lot of potential checks and be able to not have that cause a problem. For things like diagnostic errors, where it's harder to figure out what's going on, that's where sometimes it's the communication of trying to talk to, say, the surgeon that did the operation and looked at it, and then the pathologist to make sure that they know what was the clinical picture as they're interpreting what the slides and the sections look like. The radiologist, I know I actually call our radiologists not infrequently and talk on the phone and look at the CT scans or x rays with them, because often when you have, oh, they presented with this history, the patients had whatever fill in the blank set of symptoms, the radiologist all of a sudden says, well, oh, well, in that case, the way those lungs look
Changes
could
everything.
also
Sure.
be these three other things. And so
Yeah.
it does change, and it provides more information when you have the chance to actually pick up the phone and make that call. But it's hard. Just
Right.
adding more tasks is always a barrier. So trying to get kind of that spidey sense of experience, I guess, is a lot of it. Of something's not lining up. I'm
Mhm.
going to actually talk to people. I'm not just going to read the written report. I'm going to give them a call and try and
Yeah.
figure out what's going on.
Yeah. So it sounds to me like communication perhaps plays a bigger role in diagnostic errors as opposed to some of the other sort of human judgment errors, things like that. Is that
Yeah.
accurate or no?
I think it's, just sort of all through. It's a complex system.
Okay.
So anytime you have a
Yeah.
highly complex system, you have a lot of complex ways that something can go wrong. From a medical liability perspective, one of the big ones for hospital medicine is that you uncover something and then don't communicate it with the primary doctor for follow-up. So
Mm.
the mass that was incidentally noted on the CAT scan that while you were looking for something else, but that needed to have a follow-up biopsy or a follow-up test done or something. If you don't communicate those, and it's very easy to lose track of the thing that's not actually important for why they're in the hospital, then that can be a source of problems. There's a lot of different professionals, a lot of moving pieces, and trying to get everybody coordinated together can be really challenging.
Yeah. Complex model, complex system for sure.
Hmm.
Well, Dr. Jackson, I want to shift gears a little bit. There isn't a practicing clinician I've talked to that hasn't just loved their operational or technological workflows. And I'm obviously being facetious here, but what so I want to talk a little bit about those operational issues and operational workflows, particularly with respect to comprehensive patient care. What works, what doesn't work.
Hmm.
What operational issues most impact care in the hospital setting in your view?
Operational issues in what way, I guess?
Operational in terms of coordination of care, in terms of it could be documentation. I mean, everything operational that goes into treating the whole patient.
Yeah, so I guess so much of what we do ends up with the documentation, and the documentation is a pretty significant burden. And
Mhm.
when you're going back to defend a case or review a case, the not having a good documented picture of what happened is a deficit, but
Right.
trying to do it in real time takes a huge amount of time. And so you'll often find people will see the patient in the morning and not finish writing their note until much later. But meanwhile, the case manager is waiting for the physical therapist to complete their note so that they can submit to the insurance company to get authorization for the rehab
Sure.
facility that will be the post hospital stay plan. And so everything is waiting for this note can't happen until this note happens, which can't happen until this note happens. And so the writing it down often feels like it's getting in the way of the actual doing the care. One of my coworkers has family in England and was talking about they would carry their paper chart. So the physician offices wouldn't actually maintain the records, the patient would. So they'd
Oh,
carry their physical chart into the doctor's office, and that person would write the note, and it would be a few words.
one way
Like,
to do it.
yeah, murmur, benign, no follow up. Done. That was the whole annotation right there, and then they carried it home with them and back to their primary office. So that obviously has its own weaknesses as well,
Right.
but the the efficiency and the fact that the time is then spent talking to the patient, examining the patient, doing the things that feel more like medical care. We're pulled away from that to attend to the computer in a lot of ways. And so that often ends up the challenge. And then you have all the various regulatory oversight, the governmental programs and insurance payer programs and safety programs and initiatives. And everything is well intentioned and almost all of it has a good reason and rationale. But when you put all of those layers together, it ends up just adding a lot of complexity and time and taking away from what it is that we wanted to do, which was take care of the people.
Yeah, that's a great point. And rarely, I'm sure you've seen, rarely when you got a new set of regulations or there's new layer of governance, rarely does that replace something, right? So to your
Mhm.
point, it just adds another layer of governance or adds another layer of we came out with this new law in addition to those that already exist, and you have to sort of see how all that works together. It's rarely is, oh, this doesn't apply anymore. Now you're following this one. It's That's typically not how it works.
And it's often hard to keep, when you have, say, a safety initiative or a quality metric or something,
Mhm.
it's based off of the data at the time that they develop the metric. But then in medicine, we're constantly doing research, we're constantly reassessing, and some of the data changes. And what is thought to be best care changes, but those quality metrics don't necessarily keep up with that evolution. To come back to sepsis, one of the groundbreaking sepsis papers that really kind of dictated how care should be directed for care of somebody who's infected had some pretty serious conflict of interest and methodological
Mm.
problems in that original research. Well, now to completely redo it, everybody has leaned into that type of care. And so
Mhm.
that has now become the standard. And so to relook at, well, which of those pieces should we actually examine again becomes challenging. Cardiac care, there's been a couple of papers that indicate that maybe beta blockers aren't as helpful as we thought they were. Well, it's
Mm.
still absolutely a quality measure because back in the day, that was one of the first line things, and it definitely had an outcome difference. But now we have new interventions, new stents, new medications, new combinations of medications, all these things come together. And so maybe the benefit of the beta blocker is less, but it's still one of the quality metrics. Are you doing this? And,
Mm.
trying to do the study to prove that actually this is sufficiently not important enough to take it off of the quality metric
Right.
is really hard. Proving a negative is a more
Sure.
challenging thing to do. It does just sort of build up in an additive manner.
I think that's exactly right. What is the right balance here? Because I mean, you're right. There's got to be some middle ground between patient carrying around his or her own medical record that has very skeletal notes,
Mhm.
and just kind of the over documentation required perhaps by payers or governmental programs. In a clinician's view, what is the right balance that doesn't overburden a clinician so they have the time that they need to properly treat a patient
Mhm.
versus documenting for purposes of patient safety and proper coordinated care and documenting that services were provided for payment purposes? Any thoughts on that? It's not an easy answer. I'm just curious if you have a point of view.
Yeah, I think, what we often find when we're reviewing charts is we're desperately looking for the free text portion that was put in by the
Mm,
provider themselves. So
mhm,
all of the auto imported, templated garbage that bloats out the note into these multi-page monstrosities. And what
mhm.
you're looking for is the one line that that doctor actually typed out or dictated themselves. So I think
That's what does it, huh?
yeah, and I think that often, that kind of highlights what it is that you'd be looking for is, really
Yeah.
looking, what are the, we're talking medical school, what's the pertinent positive, what is the pertinent negative? So when you're taking a history, you're having somebody tell you their story and you're trying to glean from that, okay, what are the couple of nuggets in here of, ooh, that was a really important thing you just said. I'm going to make a note of that and follow up a couple clarifying questions and really know. But telling me all about your third cousin Gertrude's sore knee back when the rain started, going to deprioritize that a little bit.
Fair enough. Fair
Um,
enough.
and so, when you're looking at the documentation piece, it's, can you manage to craft a note that highlights what are the couple of symptoms that brought them in? What are the couple of pertinent exam findings that support or refute the concern? And then what are you going to do about it? And what is your thought process for why that's what you're going to do about it? So that then the next person who picks up their care can see, well, what they were telling the doctor before me was actually different than what they're telling me now. So that would be how they got off on that path that I think might be the wrong one.
Right.
But what they were thinking clearly makes sense for the information they had. Now we have more information and we're going to go off in a different direction. And so being able to see the kind of the thought process and the evolution of it, I think is the useful part of the charting. But when you go through and document that you met the quality metrics and did all of the required mandated things and included all of the codes, and by the
Mhm.
way, I needed this extra thing because that increases my reimbursement from the insurance company if I don't include the specific language. But you've got to skim over all of that to see, but where was the one liner of
Yep.
what it was that person was actually thinking somewhere in
Yep.
there.
All the condition codes and all this
Mhm.
stuff no, that's a great point. Dr. Jackson, where do you see the biggest risk points in hospital medicine?
Historically, the liability risk has always been in uh, missed diagnoses or missed kind of what I call incidentalomas, things that get
Mhm.
found on a scan that turns out that is the cancer, but you didn't remember to tell anybody that there was a thing in there that then 6 months later, when it manifests as the cancer, and then you look back and say, oh, they knew about it and you didn't know to
Right.
do anything. Yeah, so that's the from a liability perspective, that's been the answer for a number of years. I think the kind of the communication and information overload and interruption overload ends up knocking off train of thought and making it harder to actually have a well-reasoned plan and communicate well. So I think in kind of the day-to-day struggle and what it is we're working to overcome, it's that everything is beeping, everything is alerting, everybody is asking for your attention all the time. And what you really want is a few minutes to put your thoughts together and then 15 minutes to sit down with the patient and their family and try and explain that. That can be hard to
Uh,
do.
but is that a risk that can be reduced at all? Because you probably have clinicians, APPs, physicians, nurses, as well as hospital administrators listening to this, and I'm sure that that's the question that'll come up because it's such a high complexity environment in the hospital
Mhm.
with patients that have a variety of different acute and chronic conditions. How can a system reduce those risks?
Yeah, so there's some initiatives on kind of focused communication, looking at prioritizing, is this something that needs attention right now versus is this something that can wait? And if it can wait, how long can it wait? Is this
Mhm.
something that needs to be addressed during daily rounds? Okay, we don't need to call in the middle of the night. We can
Right.
just pass it forward until daily rounds? Is this something that we can structure multidisciplinary rounds for a unit? So you have the physician, the case managers, the dietitian, the therapists, the nurses all together to be able to bring forward concerns and actually have that communication all at one focused time. And that can be very beneficial. There's training for kind of messaging discipline. Yeah, there's a communication function within the EMR that will send a notification to you every time there's a new message. It's sort of like, text message on your phone dings and that's another emoji or
Right.
whatever, which if you're just in a text thread and it's a bunch of friends, ha ha ha, isn't this funny? But if you're actually trying to concentrate and this thing pops up, but it's not actually value added communication, that just took you off of your concentration. And it takes a little bit to rebuild that concentration and get back to the task that you were doing. And so there have been in the literature some institutions that have been really proactive about that messaging discipline and
Mm.
focusing on kind of appropriate communication in an appropriate way, in a way that is less intrusive or kind of the right amount of intrusive. Interrupting when you need to interrupt, having it come in on the back burner when that's an appropriate timing piece.
Sure.
That's one, as there's so much turnover in the industry, there's people are moving jobs all the time. It
Mhm.
gets harder to really build that culture and that community for how do you work together as a complex team.
Right. You build that culture, you build that trust with each other, you build those expectations. And then, yeah, I mean, retention's an issue. And then you have to
Mhm.
sort of start from scratch in some cases. That's a
Mhm.
great point. I want to look forward, Dr. Jackson. And you've been practicing for some time, but how has and how is hospital medicine evolving from your perspective?
Where is it going from here? There've been a few trials, and they did some of this during COVID times, looking at the hospital at home model. Can we
Mhm.
bring people to your house rather than bring you into the hospital?
Right.
And so I think both from a comfort perspective, most people would rather be at home than be in a hospital. Kind of a complication perspective, you're less likely to run into a problem of a complex system if you're in a simpler system in your home surrounded by caring loved ones, assuming you have a safe home with adequate caring loved ones to be able to do so. And then bringing the medications, the nursing interventions, the physician assessments, bringing that to you in the home. I do think there's a lot of opportunity for that. And I think that it will probably continue to evolve so that people who are hospitalized are functionally in an intensive care level. And it's only to the
Mhm.
point that you're really needing a level of intervention that can only be provided in a building where everybody is right there and immediately available rather than
Right.
having to drive over to your house to see you. The technology piece is interesting, kind of what comes in the future. Right now, everything, well, AI is going to do it all. And I think there's sort of two problems with that in medicine. One is, I talked about how just messy the charts are. People are just putting in whatever diagnosis gets them through the visit to try and take care of the patient while putting as little time and effort into dealing with the computer as they have to be able to do the patient care that they want to do. And so I think the data in medicine as a result is sort of atrocious. There's just a lot of slop in the underlying data because everybody's just trying to make do and trying to work around the system they're in to be able to try and provide great care for the one patient right in front of them. And then you add into that, a lot of the studies have limited populations, especially in geriatric medicine. A lot of trials don't enroll anybody over, say, 70 or 75 years old. Well, if you're 85 or 90, how does the result of that trial truly translate into your individual care? And one person's 85 is very different from another person's 85. You can have wildly
Right.
different levels of health and vitality. I think it's going to be a real struggle to have a lot of the protocolized and technology driven implementation of care without figuring out a way to individualize. And so I think that's going to be another challenge is how do you continue to put into context what are the psychosocial relationships and priorities for the individual patient? How do they align with what does the big data say about what should be happening to their care? And so there's been a lot of talk of personalized medicine from a genetic perspective. Oh, we're going to sequence your
Mm,
DNA and be able to know exactly what we need to do. And I think it loses that an awful lot of personalized medicine is more, who are you? What's important to you? What's
right.
important to your family? How do you prioritize all these different things? And I think kind of our role in medicine is often going to be trying to interpret and navigate that discrepancy between, well, big data is telling us and the algorithm is telling us that here's what you should do, but why don't you tell me your story? And yeah, the words you said, so if you were typing it into a chat bot, the words would say one thing, but I saw when you teared up and I saw when your
Mhm.
shoulders shook, and that actually tells me something different than the words you were telling me. How do you navigate those
Yeah.
discrepancies?
We're not quite there yet where AI is detecting emotions. Is that what we're saying?
Not accurately.
Not accurately, right. I totally agree with everything you said. I mean, the hospital at home stuff, I mean, CMS recently extended that program. I can absolutely see that evolving. I think it's been fairly successful and absolutely can see a world in which that grows within the next 5 to 10 years. The AI stuff is really interesting to me as well, where I mean, look, I mean, it's pretty rampant right now in the radiology world. We know a lot of systems are using it for encounter notes, and there are some CDS platforms out there for clinical decisions,
Mm.
decision support, but there needs to be a lot of governance around it, and there is. FDA has come out with guidance on what a CDS should do and shouldn't do. But I agree. I don't think 2 days, 2 or 3 days pass by where I don't get a call or one of my clients don't raise some question about AI, whether it's their use of data or it's a vendor's use of data, or I mean, it is huge, and it's only growing in the next 5 to 10 years. I mean, my mind can't even comprehend probably where we're gonna be in 10 years with that.
And at least right now, a big problem I have with it is that I think a lot of these AI companies and the clinical decision tools and radiology interpretation, they're sort of hiding behind the skirts of the individual license of the
Mm.
physician.
That's the fear FDA has, right? I mean,
Yeah.
that's what
And so when something goes wrong, when the computer tells you the wrong answer, whose fault is that? And I
Mhm.
think from a really legitimate liability perspective, it ought to be the corporations. And I think we really need to get liability law to align the fact that if you're having a corporation, if you're having an algorithm be the thing that's practicing medicine, well, that's where the medical liability lies. I think until we get that, there's going to be a lot more resistance because the ownership of, I have to own my own decisions. I have to own my own mistakes. Does whatever AI thing, are they held to that same standard?
Right. I mean, before we even get there, I can imagine licensing boards, right? Medical licensing boards
Hmm.
having a conniption fit with even the thought of some algorithm practicing medicine that could raise a whole host of issues. But I really appreciate your time. I've learned a lot. This has been a fascinating discussion. Dr. Jackson, every episode I end with a little lightning round. Just three quick questions that I'm going to run by you. But as always, our lightning round today is brought to you by Western Associates. They specialize in high quality branded merchandise, things people actually keep and don't throw away. I'm actually wearing a Health Law Council branded quarter zip today that is from Western Associates. So if you're thinking about upgrading your organization's brand through custom products, check them out at westernassociates.com. I will drop a link in the episode description as well. Okay, Dr. Jackson, one thing people misunderstand about hospitalists.
Think that we know their whole backstory. So I
Mm,
think there's an awful lot of, why are you asking me these questions? It's in the record. But
mm,
how many things are wrong? How many things are incomplete? How many things are more? So that idea that just because I have access to your record, I actually know you and understand you without getting the time to sit down and talk to you is,
right.
I think, one that I encounter a lot.
Sure. One fix that would immediately improve care coordination.
I mean, wave a magic wand. I think if we had completely restructured the entire payer structure in this country to prioritize primary care, that would then snowball into more coherent care plans, more coherent communication. And when people arrived in the hospital with us, they would have a more linked network of specialists and providers that we could then pick up a coherent plan and run with it when they were in crisis. That should be easy, right?
Yeah. I love that response, and I honestly, from clinicians, I hear that all the time, and just that focus, the importance of that focus on primary care. I'm with you 100% on that. And finally, Dr. Jackson, book your reading, podcast you're listening to, or show that you're watching. This is more for just my own curiosity, but we'll throw it out for everyone.
Boy, this is going to out me as an NPR nerd since both the book and podcast. I'm reading the Planet Money book right now
Okay.
and listen to the Planet Money podcast. And then another regular podcast is Marketplace, since I can almost never catch them in their mid afternoon broadcasts.
Right.
So I pick up later in the day.
I love it. There is nothing wrong with being an NPR nerd. I'm with you there 100%. I think that's great. Well, Dr. Jackson, I want to sincerely express my gratitude to you for your great insight, for now some time and what I know is a very busy schedule, sharing your great insights with us today. I learned a lot about hospital medicine, hospitalist, care coordination. I mean, you really educated us on hospital medicine and the associated risk points. So I really appreciate it. And thanks all for tuning into Health Law Pulse. Take care. I appreciated this conversation with Dr. Jackson, and I want to thank him for his time. It was really interesting to me pulling back the curtain on what hospital medicine actually looks like day to day and the complexity that exists behind the scenes in patient care. A few takeaways that stood out to me. First, what looks like a clinical issue is often really a communication or systems issue. Second, coordination of care isn't just an operational concern, it directly impacts patient outcomes and safety. And third, many of the biggest risks in healthcare don't come from a lack of effort or expertise. They come from small breakdowns of communication, workflow, and transitions of care. Thanks again for joining me and sharing your perspective, Dr. Jackson, and thank you all for joining me on Health Law Pulse. At the end of the day, great healthcare depends not just on individual decisions, but on how well entire teams and systems function together under pressure. This is Health Law Pulse, and go Avs.